Good afternoon. I'm Tammy Coleman-Epps, and I am the Director of Media Relations and Social Media here at Prisma Health. And this month is October, Breast Cancer Awareness Month. We are at Prisma Health always concerned about our community and always working hard to help our community have the information they need to take care of their health. In honor of breast cancer awareness, we put together a panel of our experts to help get the information out to our community. So we're here today with that. And so on our panel, and I'm gonna get this name right, we have Dr. Naru Ane. I hope I got that right. And she is a new surgeon with us here at Prisma Health. She also is an assistant professor at the U of SC School of Medicine in Columbia. And then we have Dr. Douglas Bull, who's one of our radiologists, and he also is a professor at the UFC School of Medicine in Columbia, an associate professor. And then we have Dr. Joe Stevenson, who's one of our oncologists. He's the medical director of the Center for Interpretive Oncology and Survivorship, and he's also an assistant professor at the USC School of Medicine, Greenville. And then we have Dr. Jerome Gilstrap, one of our plastic surgeons. So this is our team. We're excited to have all of them to share really important information with you today in honor of breast cancer awareness. With that, I'm going to start with Dr. Ane.
Hi, Tammy. Thank you for inviting me to speak at this venue. I'm super excited to educate the community.
Good, I'm excited to have you here. Thank you. And we're glad to welcome you here to Prisma Health.
Thank you very much. I'm a board certified general surgeon and I did cancer surgery fellowship, including breast cancer surgery. I'm thrilled to be part of this community in Columbia. I relocated because of family. I can't wait to start meeting more people and start working with you.
Good, thank you. So we're going to start with a kind of common question, Dr. Ane. How common is breast cancer and who is at risk?
1 in 8 women, unfortunately, develop breast cancer. Age is a risk factor for developing cancer, as you know. Breast cancer, in fact, is the most common cancer across the world, with the exception of skin cancer, right? Next to skin cancer, the second most common cancer is actually breast cancer. And women, unfortunately, should be aware and be careful in terms of screening. Mortality from breast cancer is the second most cause of mortality after lung cancer being number 1. Any woman over the age of 40 should be having screening mammography to decrease the morbidity and mortality associated with breast cancer. Breast cancer not only affects women, but it actually affects their families. And so men and women should be aware of breast cancer. All those men who are watching the video should really encourage all the women in their lives to undergo annual screening mammography.
Good. Well, we appreciate that answer, Dr. Ane. We're going to go to Dr. Stevenson and ask him a question about what groups are at risk. All right, Dr. Stevenson, are there certain groups that are more at risk than others?
Right. So there are certain groups that are more at risk. Certainly, those patients who have a strong family history, those patients who have a known genetic mutation, although that's relatively rare for the vast majority of breast cancer, gets a lot of press, but that group is at higher risk. There are certain ages, so generally in the late 50s, early 60s is median age for the diagnosis of breast cancer. And then there are certain things, that we'll get into, I think, later on in terms of, behavior modification, those sorts of things that also put patients at a higher risk for breast cancer. And so hopefully in the course of this, we can talk a little bit in regards to prevention of breast cancer, because that's been the focus here at Prisma for leaning into prevention as well as early detection. And so being able to pick those patients out who are at higher risk, and there may be some intervening things that can be done to change that statistic that Ann talked about, that 1 in 8, which has been around for as long as I've been a doctor, an oncologist for 24 years.
Yeah, okay, we're gonna go to Dr. Bull. Dr. Bull, so I think Dr. Stevenson started this conversation, but we'll continue it. Is there anything a woman can do to lower her risk of breast cancer? I'm sure that's going to be a theme we talk about this whole time, but.
Right. Well, to begin with, there's no surefire way to prevent breast cancer. All women are at risk for it. It increases with age. For the general population, the things that I'm going to say next are just things that your family physician or even your mother would have told you years ago and 100 times, and that is maintain a healthy diet, be as physically active as possible, and limit alcohol intake. Those 3 things have been proven to have some effect on the risk for breast cancer. And then for younger women who are childbearing age, there is some protection if you breastfeed your children. There's a protective effect there. And then for older women who are postmenopausal, think very carefully about estrogen hormone replacement therapy. It was much more common in the past few decades than it is now, because it has been shown that it does increase the risk for certain types of breast cancer. So those things altogether are ways to lower the risk, but again, there's no way to prevent it completely. So.
Yeah, I'm going to go back to Dr. Ane because I think she wanted to add a comment.
Sure. I'd like to add a comment to what Dr. Stevenson was saying about the risks of breast cancer. In addition to the groups that he had mentioned, women with family history of breast cancer, meaning the woman herself does not have breast cancer but has family members like a mom or a sister or first-degree relatives who were affected with breast cancer, or has 3 generations of relatives who had breast cancer. These are individuals that are at an increased risk of developing future breast cancer themselves. And Dr. Stevenson had mentioned that these women really belong in a high-risk breast program where they could be advised regarding their elevated risk of developing future breast cancer and appropriately screened with breast MRIs in addition to mammography and ultrasounds, in addition to genetic counseling and testing for the BRCA, as well as other mutations that could elevate a woman's risk even further for developing breast cancer. So we are in the process of building such a program here in Columbia to provide services to our community where we can reduce these women, provide them the proper counseling regarding their elevated risk of breast cancer, such that they can avail the breast MRI in addition to mammography and on an annual basis as a screening tool, as per the NCCN guidelines. So it's very important for those women who have family history of breast cancer to be proactive and to make sure that they obtain the proper counseling regarding reducing their risk of developing future disease. Now, I'd like to add to what Dr. Bull had said. Obesity and elevated body mass index are a risk factor for developing future breast cancer. Individuals who are obese, they do have elevated estrogen levels, just like what he had mentioned regarding hormone replacement therapy and taking estrogen replacement therapy. These individuals have an elevated risk of breast cancer. So there are ways that we can mitigate or decrease the future risk of developing breast cancer by providing proper cancer risk reduction counseling and referring these women to proper nutrition consultations and working with them such that we can collectively achieve the goal of reducing their body mass index and by decreasing the future risk of developing breast cancer.
Good. Well, Dr. Ann, while you were talking, the next question was really about some of the symptoms of breast cancer, and is it always a lump?
Well, ideally, Tammy, I think all women should undergo mammograms starting at the age of 40 every year. so that they never have to deal with finding a lump. But since you're asking what are the concerning signs for a breast disease or breast cancer, it could be a lump, it can be nipple discharge, changes in the skin, any discrepancy in the size of the breast compared to the opposite breast, or any changes, hardening, thickening, or anything that the woman notices as a change to her breast would be concerning. And these women who believe that they have changes in their breasts should seek their primary care physician or OBGYN immediately, such that they can have proper diagnostic workup and be referred to a breast center for further evaluation. But ideally, we really would like women to undergo the screening mammograms such that the X-ray can actually pick up any subtle changes in the breast before a woman feels a lump or a mass or has a nipple discharge or has any of these signs or symptoms.
Good, thank you. I'm going to go back to Dr. Bull. Dr. Bull, I think
Yes.
Dr. Ane started the conversation about when you should begin having your screening mammograms. So what would you like to add to that conversation about when people should start?
Well, people read different things, and there's controversy out there about who should get them and how often. Our stance here at Prisma Health has been starting at age 40, annual mammograms starting at age 40. Some women can, if they start later, they can have a discussion with their primary care physician. But starting at age 40 annually is what we recommend. And it's in line with a number of major health organizations and medical groups. There are some that recommend different, starting at age 50. And even start having biannual every 2 years instead of every 1 year. But our stance is, again, we recommend starting at age 40 and once a year. That's what we find the most effective and the best way to find early breast cancers.
And what's the difference between a screening mammogram and a diagnostic mammogram?
Well, a screening mammogram is basically designed to be a quick, low cost, but effective screening procedure. So you come in, you get a limited history, get the views of each breast, and then the patient rests and goes. And it's read after the fact. And we found to be the best screening process to keep the patient flow and be able to manage a large population. Those are quick and fast, and we often find things that need to be looked at differently. A diagnostic mammogram really includes the same views as a screening mammogram, but it also includes anything extra that is needed. It's usually a procedure that's managed on the fly in real time. If we need extra views for something here and there, we do that while they're there. Oftentimes an ultrasound may be needed, and we proceed with that also. So it's a managed mammogram procedure while the patient is here, different than a screening where the patient comes in, gets the pictures, and leaves.
All right, I'm going to go back to Dr. Ane. She wanted to add something to that about the screening mammogram. Dr. Ane?
Sure. Thank you, Dr. Bull. I agree with you completely. The screening mammography is recommended by the American College of Radiology as well as the American Society of Breast Surgery and American Cancer Society, and they all are in agreement that every single woman over the age of 40 should undergo a screening mammogram every year. Of course, there are some literature bodies and studies that do differ with this, but the medical societies that sort of compel us with recommendations and what we consider standard of care today, such as the American College of Radiology and the American Society of Breast Surgery, these are in congruence and they're in unison when they recommend that each and every woman should undergo a screening mammogram starting at the age of 40 on an annual, which means every year basis. Now, these are women who are at normal risk. meaning those women that do not have risk factors, apart from being a woman, are the ones that should be undergoing mammograms once a year, starting at the age of 40. Women who are considered to be at high risk for breast cancer, which is what Dr. Stevenson had talked about before, are women who not only benefit from a screening mammogram on a yearly basis, starting at the age of 40, but these women, in addition, should be undergoing screening breast MRIs every year, as recommended by the American Society of Breast Surgery, as well as the NCCN guidelines.
Yeah, thank you, Dr. Ani, for adding that. So, Dr. Bull, so I
Yes.
personally have had a mammogram that started at age 40, like I'm supposed to, followed all the rules. So, but what should be, some people are still kind of afraid of having mammograms. So what should somebody do to prepare for getting their mammogram? Are there things they should or should not do?
Well, the first thing, and to me, one of the most important things is we recommend sticking with the same facility or the same healthcare system as long as you're happy with what they're doing and how it went last year. The reason for that is it is of utmost importance to have comparison studies to look at and look for subtle changes from year to year. I can't stress that enough. If you are coming from one system to another to get your screening mammogram, please try to get your old mammogram studies on a disc or have them somehow available so they can be provided to the new facility or the new healthcare system, because making a comparison is often one of the most important things. Beyond that, if you don't bring them with you in a disc, or if they're not available immediately, be sure you provide information to the new facility so that they can be obtained. But again, if you're getting your mammogram at the same institution year after year, they will have priors to compare to. We typically compare to anywhere from 3 to 5 prior mammograms on almost every screening study that we read, if they're available. Beyond that, it is helpful. A lot of women may not be aware of this, but we find it to be helpful if you are premenopausal and having menstrual cycles, to try to schedule your mammogram somewhere around the second week, day 7 through day 15 or 7 through 16. That is the time of your cycle where the hormonal influences on the breast tissue are least prominent. It's probably the time where your breasts are less likely to be more tender. And it also, because the effect on the glandular tissue is less at that time, it's a little bit lower chance of having a false positive, calling a patient back for something that just turns out to be a physiologic condition that can happen through the cycle. Beyond that, it's important to try not to use deodorant or antiperspirants, lotions or creams on the breast or under the arm on the day or the day of the procedure. It can mimic calcium deposits on a mammogram. We can usually deal with that and get around it, but it takes some work sometimes. And of course, something just simple as wear easy to remove upper body clothing for the procedure. Those are some of the main things to consider.
So wait, Dr. Bull, are you saying like the day that you could come to get your mammogram that you shouldn't wear deodorant?
That's what they recommend. There are some deodorants that have, especially antiperspirants, that have little aluminum flecks in them, and it can mimic calcifications. Again, it's usually under the arm in the axilla and not on the breast. So we are able to deal with it most of the time, but the recommendation is to limit that until after your procedure is done for that day.
Thank you. There's a lot of conversation about 3D mammography and whether certain people should have 3D versus others. Can you talk about that a little bit? And are there times when this type of mammogram would be preferred over the regular 2D mammogram?
Well, we have 3D mammography I believe at every facility in the Prisma system. It's been around roughly 8 to 10 years now. We've had it here in the Midlands for 7 and going on 8 years now. It's a mammogram, but it's a different way of doing it in that it uses a computer generated series of images that actually lets us go through the breast in slices, if you will. It's most helpful for women who have denser breast tissues, but it can be beneficial for many women, even with not very dense breast. Right now, we're probably doing 80% of our mammograms, 75 to 80% are 3D. I believe there is a population of people who don't benefit as much from it, and that's the people who have very little glandular tissue, what we call a fatty tissue breast, which is much easier to see things and easier to find things. And I think it's appropriate in some cases that they might not need a 3D mammogram. And that can be discussed with the technologist on the day of the procedure or with your referring physician, because they usually have a report describing what the last year's density was. The 3D mammogram, it's more cost involved, a little bit more cost. There's slightly greater radiation, but not a great deal. It's about 15 to 20% more radiation. So there's things to consider, but in general, like I said, most patients that are coming to us now, and I know in the upstate too, are getting the 3D mammogram.
Yeah. I personally had an opportunity where I got called back for something that was nothing, and that's pretty scary, even though they tell you it's nothing, so what does it mean if somebody gets called back, let's take another look.
Well, I'll start by saying here in the Midlands, it's about somewhere around 8 to 10% of our patients that do screening mammograms. In that 8% number do get called back for something that we just need a little closer look at and want to do some either an ultrasound or some additional mammographic views. Fortunately, the vast majority of the patients who are called back, we find nothing of significance. Nothing needs a biopsy, nothing needs surgery. We were able to resolve it. We find cysts, we find benign conditions that can explain what we're seeing. So only about 20% of patients who are called back end up getting something else done, such as a needle biopsy. And fortunately, only about 30% of those are turned out to be cancer. So as you whittle through the hierarchy of screening mammograms, the recall visits, the needle biopsies, it turns out that a very small percentage on an annual basis of people who get screening mammograms actually have breast cancer that we see. So, yeah. But that's what it's about. What I would like to tell women is don't get too upset because you have to come back for something, because the vast majority do turn out to be benign with nothing of significance. There's a small percentage that we have to move down the line and do other procedures with, and like I said, a small percentage end up having cancer. That's why we call them back, to get a better look at things.
Well, I was glad to say that I got called back, and it was a very quick visit, and all was well.
Yeah.
I'm going to go back to Dr. Anne. She wanted to add something on 3D mammography and on that distinction.
Sure. So Dr. Bull had mentioned dense breast tissue. I just wanted to clarify that to some of the ladies who are watching this. Dense breast tissue just means that the breast has a lot of milk glands and milk ducts and has very little fat tissue. About 50% of the women in the United States have dense breast tissue. 3D mammography really assists the radiologist, like Dr. Bull had said, in terms of finding small cancers in women with dense breast tissue. There are a lot of studies that show that women who undergo 3D mammography, their recall rate, which is getting called back like you did, Tammy, is much lower. And the cancer detection rate is much higher when you undergo a 3D mammogram. In some parts of the United States, 3D mammography is in fact the standard of care for those communities, meaning that almost all women are having 3D mammography only. So the take-home points about 3D mammography are that 50% of women in the United States have dense breasts. So, which means half are women who are undergoing the screening. And 3D mammography increases cancer detection rate and decreases the recall rate. So for those women who have the opportunity and the option of having 3D mammography in their communities, they should really avail that.
Yeah. I was gonna say, one of the things that we raise funds for, have raised funds for with our Walk for Life and Runs for Life, has been to and make sure that we had 3D mammography, including on our mobile
Absolutely.
Yes, so
Absolutely.
yeah, I'm gonna go to Dr. Stevenson.
Yeah, I just wanted to say, you know, it may be at the end of the day, as Dr. Bull and Anna have mentioned, that there is all patients may wind up not requiring a 3D mammography. There is a large 100,000 patient national trial called the TMIS trial that Prisma Health has been a very important part of, to kind of validate 3D in a fashion. And it may be that when that data is done and interpreted, that there's going to be some, you know, distinction between, is 2D enough for someone maybe who's older, has a more fatty breast, and that person doesn't need 3D, and the radiologist and the breast surgeons can kind of sort that out a little bit. So I think it's been an incredibly important tool for reducing callbacks. Without question, it is a standard of care, without question. It may be that there is, just like for breast MRI, there's going to be certain indications for its use going forward, but that's still up in the air with the TMIS trial. But we're participating in that trial, and I think we're around 70,000 patients nationally now.
Right, that's what I've heard lately.
Yeah.
Yeah.
So that's really encouraging. That's a huge undertaking, and they almost pulled it a few years ago, and you know, but the credit to the radiologists and the breast surgeons and the community at large for, you know, pushing forward and really embracing that very important study. So
Well, Dr. Stevenson, while you're on, you know, there's a lot of myths about what causes breast cancer. Of course, we talked about earlier who could be at a higher risk. We talked about some of the things you can look for. Dr. Ane talked about some of those things. But can you address some of the myths that, you know, wearing deodorant, wearing the underwire bra, having implants? Do any of those kinds of things impact your risk for breast cancer?
Yeah. So in terms of deodorants, that's been out there for a while. And, you know, there are certain, we actually talked about it earlier, you know, some of the different components that make up deodorant, but there's been a lot of actually studies that have looked at that because it kind of makes sense, you know, underneath the arm and that sort of thing. And so I can see why people may have that, but I think that's been pretty much debunked now. There's actually AICR looked at this in you know, mid 2000s and found no association. So I think we can put that one to bed, that there is no association with deodorant and increased risk for breast cancer. Same with underwire bras. I think that's there's no evidence to suggest that at all. So I think we're good there. But and then in terms of like implants, I know someone asked about that not too long ago in breast cancer risk. I mean, there is, and Dr. Our plastic surgeon, Dr. Gilstrap, sorry, if he is able to make it, could maybe address this too. But there is a form of lymphoma. It's very, very rare. It has to do with a certain type of implant that's been associated with a type of lymphoma. But I don't think there's any real significant increased risk for developing breast cancer in patients who've had implants. There is a variation on that theme with a very highly treatable form of lymphoma that's associated with a type of breast implant.
Right, I'm gonna go ahead, Doctor. So I was gonna go back.
Outside of that, I'm not aware of any other data correlating implantation with breast implants or augmentation with breast cancer.
Well, I'm glad to hear that about deodorant because I have so many friends who we've been having this conversation about natural deodorant versus regular deodorant and whether that puts you at risk for stuff, and you know, and this deodorant doesn't work as well as the others, and you know, all of that.
Right.
So,
oh yeah. Yeah.
Yeah.
Yeah. But there's a good website that deals with, stick to the science is what it's called. And it kind of addresses these as they sort of get into the lexicon of the community in terms of, risk and cancer and those sorts of things, and tries to address that to the best that it can, and allaying a lot of fears or validating. I mean, sometimes, they're real. So, but in the case of deodorant, there's no, and that's been looked at, there's no association with use of deodorants that were looked at back in the mid 2000s. So
I'm going to go to Dr. Ane. Dr. Ane, one thing you wanted to address something about the implants.
Sure. About the implants, it's more of a comment, and I would like to bring Dr. Bull in for a comment also. There is a lot of data from the American College of Radiology regarding the difficulty of performing screening mammography in women who have had implants for breast augmentation, due to the difficulty of being able to view or interpret the posterior breast tissue, because remember, the mammogram is an X-ray, and when you're trying to take an X-ray of tissue that has an implant behind it, that solid material or the material from the implant can also obscure the views for the radiologist. So I wanted to request Dr. Bull for a comment regarding this.
Okay, Dr. Bull.
Sure, there's no doubt that the implants do or can, in some cases, obscure some of the tissues. On almost all implant patients, we take extra views, what we call implant displacement views, where the implant is pushed back out of the view of the image. And this allows us to capture as much tissue as possible in front of and around the implant. And I think our technologists are well trained in doing this. We have a lot of implant patients. Just this morning, I probably, out of about 30 screening mammograms, I think I've read 7 or 8 or 5 or 6 implant patients. So it's very, very common on a daily basis. So it is something that the technologist doing the procedure is trained to do, and most of them are highly skilled at it. Is there a chance that an implant patient, we're still not seeing quite as much breast tissue as someone without implants? Yes, there is. There's always that chance, but we do the best we can, and we take special precaution with extra views to try to avoid that.
Well, good. That's good information for those out there who have had that. With that, I'm going to go to Dr. Ane again about related to is surgery always needed to treat breast cancer, and what are the surgical options?
Well, Tammy, breast cancer, early stage breast cancer, the mainstay is surgical treatment or local control. When I say early stage breast cancer, I'm referring to those women who have stage 1, stage 2 cancers, right? So we do offer surgical therapy up front, along with local control, which includes radiation and systemic chemotherapy if indicated. Now, stage 3 breast cancer, a lot of these women undergo chemotherapy up front. They do chemotherapy first, and we reevaluate the patient, and then we offer them surgical therapy and radiation therapy for local control. Stage 4 breast cancer, there's a lot of controversy regarding whether women actually benefit from surgery or not. There's 2 schools of thought. Obviously, there is a school of thought that believes that surgery should be offered to women who have stage 4 disease, because they believe that the primary tumor is actually generating and or secreting certain molecules into the bloodstream that make the metastatic or the other tumor sites in the body worse. So that train of thought is that the primary index tumor in the breast is actually sort of controlling and or sending signals to the other sites in the body. The second school of thought in a person who had has stage 4 breast cancer is that stage 4 breast cancer is a non-surgical condition, and the patient would benefit from systemic treatment options, including targeted therapies, as well as, if necessary, some chemotherapeutic agents if indicated. And there's no surgical therapy role, or there's no role for surgery. So I would never say that surgery is the answer or not the answer. You have to evaluate the individual person and their medical conditions, including their comorbidities, what the person can and cannot tolerate. Their anesthetic tolerance needs to be considered when we look at surgical options. Of course, the surgical options are lumpectomy or breast conservation, which means we remove the cancer, but preserve the breast. The other surgical option would be to remove the breast or to perform a mastectomy. In order for us to consider the surgical options, we have to look at the individualized treatment plan for the patient, which is based on their history, their existing medical conditions, their current cancer stage and diagnosis, and the best treatment options that are available to that patient. You also have to remember that we're in the world of tumor genomics, where each and every person's cancer care should be individualized based on the genomics of the tumor, which includes the tumor subtype and the receptor statuses. So one treatment does not fit all. We had to individualize the treatment plans for the patient, whether it is systemic treatment options, surgical options, and or the survivorship plan.
Yeah, so I'm gonna go to Dr. Stevenson. Dr. Stevenson, I know that one of the things that Dr. Ane was talking about is individual plans. And I know that after being at the hospital for a long time myself, that we have the breast conference for each patient. So can you talk a little bit about that so that people understand that all the doctors work together to come up with the best plan for the patient?
Right. Yeah. So if I could, I feel like I'm in a debate. But if I
No,
could,
not debating.
not debating anything, but I'd like to I want to tag on to the mammogram just for a minute.
Sure, go ahead.
It's a
Go
full
ahead.
public service announcement, I guess, as much as anything. But it kind of leads into what we've talked about for the first half hour, and that is breast cancer prevention. So breast cancer prevention, wouldn't it be great if Dr. Bull didn't have to see any of these cancers, or as many of them, and Anna didn't have to take as many out in this 1 in 8 number. I just want to hit this really hard for just a second. So the 24 year that I've been in practice, the 1 in 8 number has not changed. It's actually going closer to 1 in 7 than 1 in 9 when you look at the last 3 quarters that it's been evaluated. And so we've had data for 20 years about how to intervene through lifestyle changes, through medicine. There's been a dramatic shift in the medicine, the dose that we use based on the Censia data from 2018. And so we have really leaned hard into this. Right before COVID, we had been meeting for a couple of years, started around the kitchen table. And then finally, last April, formally adopted this and now leaned into it, pushed it into the mammography report, which you'll start seeing, where you'll have a Gale score, and that Gale score is critical to determining risk assessment. It's and the way that we view it is just like mammography, as Dr. Bull mentioned. It's a screening tool. You're trying to get 50 million women evaluated on a yearly basis. And so just in that sense, the Gale score is, in the Tyrer-Cuzick are screening tools that allows for potential different ways of managing that patient, just like you might from the radiographic findings from mammography change the way you image those patients. And so you will start to see the Gale score in your mammography report along the Tyrer-Cuzick, and that's meant to just be a means to generate a conversation with your primary physician regarding what are the implications and how can we address that? And so we've got this breast cancer prevention clinic that's been set up that kind of coordinates all of this with nutrition, genetics, all the things that we've talked about, medicinal interventions. How do you image them appropriately, and screening and follow-up? So it's a really important tool that we put together and spent a lot of time thinking it through. And that's now in place, and that's going to be hopefully a part of changing that number and getting that 1 in 8 to 1 in 16. Because it's about a 50% reduction in developing breast cancer when in the right patient population utilizing these tools. So it's really, really impactful. All right, so moving on. So your question was side effects of cancer treatment or the breast cancer clinic. Yes, so the model that we use is called the multidisciplinary model, and as Anna said, breast cancer is multimodality treatment now. When I walk into a new room, new patient, new room, I always talk about the buckets, and we have these boards on the wall. And I say there's a local treatment and a systemic treatment. Local treatment is surgery, radiation. Systemic treatment is chemotherapy and anti-estrogen therapy. And then, I do a little personal story. My mother was 26. She had a Halsted radical mastectomy because at that time we only thought surgery was the way to cure all these patients. And so the bigger the margins, the more likely the cure was the prevailing thought. And then unfortunately, some of these women would relapse a couple of years later. And so clearly, the surgeon would say, I can't cut anything more out. There must be something more to this story than just surgical margins. And that has been transformative in that observation, because it is our whole thought process has changed. And so now our surgeries have gotten much more reduced and refined. And you now have things like lumpectomy for a vast majority of patients, plus minus radiation, the sentinel node versus the full axillary dissections, cut down the lymphedema. Those are important pieces. And then you marry that to, chemotherapy or anti-estrogen therapy in coordination and as a part of the total plan. And it truly is a multidisciplinary approach. And so in the past, we've had these patients go from the surgeon to the medical oncologist and then over to the radiation doctor and then back. And there's just all of this. So what we've done is just we set these clinics up. Right now there's 2 a week. There's probably getting ready to be 3 a week. And then in those patients, they meet the nurse navigator. They meet the surgeon. They meet the breast radiologist. They meet the breast radiation doctor. They meet the breast oncologist. Our pathologists look at it, and we kind of meet ahead of time, go through each new patient, kind of develop a plan, thought process, take into account some of the molecular diagnostic pieces that Anna was talking about, and then pull that together, and then go into the room and sort of relay all that information and get the patient input and start to build a process for how to manage the patient when they leave. So all the patients leave with a plan in place and schedule in place, and they know exactly what the next step is going to be. So it's really been very well received by our patients. We've been doing it for, I'd say, 8 or 10 years now. It's a well-run organization, and with a lot of great people helping out. And it's good for us just as physicians to sort of, iron sharpens iron, and we kind of all talk about these things. And I've learned so much from my colleagues, and that's been helpful as well. So it's just a coordinated effort. And I think the patients feel that when they leave. So does that answer the question? I know I went off.
No, I think that's good. No, that's great.
Okay. Right.
Well, I guess we want people to know that I think I'm going to go back to Dr. Anne because she wanted to add about individual care. But I think the whole idea is that we want people to know that our team is looking at each person individually, but also comprehensively, all the disciplines working together, not the surgeon by themselves or the radiologist by themselves or the oncologist by themselves, but as a big team looking at what the best option is. Dr. Anne, did you want to add to that?
Absolutely. Nobody works in silo, as you had mentioned. It's a team approach, which includes the surgeon, the medical oncologist, the radiation oncologist, radiologist, pathologist. It also includes our nurse navigation. Team members include the physical therapy department, genetic counseling, and testing. But the biggest part of the team here or anywhere where we have a successful breast program is the patient. The patient and her family, or the family members, the loved ones and the patient are equal team members, and actually they constitute the biggest portion of the team. The medical team is here to make medical recommendations, but 90% of the cancer care is the woman or the man, whoever's going through care, it's their individual belief that they are going to fight this cancer. 10% really is medical care. We're here to support the patients and their families in every way. We can only make medical recommendations. But when the patients actually believe that they're going to be able to do the treatment and they will fight the disease with that inner strength, then the team is a success, or we have a successful outcome. We can only be successful together if we travel together, side by side, hand in hand, day in, day out, one day at a time. And the medical team is here to support our patients, and we work in unison, but a large portion of our team is actually the patient and the family that's involved. And we revolve around our patients and their families.
I agree with that. I mean, we all are working together all the time to try to do the best we can for our patients. I'm going to ask this question about second opinion, Dr. Stevenson. One of the things that we talked about, we just talked about, Dr. Ane talked about, you talked about, Dr. Bull talked about is, we give the best information to the patient, and we say, this is the plan that we have laid out, this is what we think. But then Dr. Ane just said, well, then it takes the patient and their family to decide what to do. So what do you say to a patient who's like, takes that consideration and says, I'd like to get a second opinion?
Yeah, we welcome it. So, that comes up quite a bit, especially in a high profile disease like breast cancer. So, just to echo what Anna was saying, one of the analogies, and Anna, you're going to learn this now that you're in the South, but football is a big deal around here, especially this time of year. And so everyone gets the football analogy of, I always say, we're going to build a team, all right? And that team is going to be the old V formation. Dr. Bull and I are old enough to know what that means. But, and all you got to do is hold the ball. You just hold the ball, and then your family, the patients, friends, counselors, the navigators, the doctors, we're going to form this V, and you just hold the ball and just walk one day, one step at a time. And then at some point, we're going to say, look up, and you're in the end zone. And that's sort of a visual that we give a lot of our patients. Part of that may be a second opinion, and we're more than happy, and we welcome either doing the second opinion or sending them out for a second opinion. The only counsel I have with that, whenever we have these discussions about second opinions, is if they have a very high risk type of breast cancer, advanced disease, stage 3, triple negative, HER2 positive, bulky disease, we do want to kind of move that along. So you don't want to have a second opinion too far out that delays the process. And so what I generally talk about is dual tracking things. So we're going to go ahead and move along our path. We're going to set up the various things that are needed. And then, we'll get the second opinion to kind of ride along beside that. And then if they come back together and we're in agreement and you want to have your treatment locally or whatever, then we haven't lost ground. So, but we're very much, we do a lot of second opinions, and then we send patients where they really want to be for a second opinion, because it is truly a matter of trust. It's a relational disease, and it's a long relationship. And we always hope for the best, but sometimes it doesn't go as we like. And if the patient knows that you've done everything possible and your team has done everything possible, then we can live with whatever outcome is happens in the years ahead. So, yeah.
I guess we talked about family a little bit, Dr. Stevenson. So let's talk a little bit about sort of some of the like side effects of breast cancer treatment, and then how can the family like support the person going through treatment?
Yeah. So, obviously there are side effects with the therapies that we give. And they vary depending on what that therapy is. And so from a chemotherapy standpoint, we really have gotten a lot better at the vast majority of the side effects that traditionally people think about when having to take chemotherapy. The two big ones that we're still working on is fatigue. That's one that we're kind of working on. We actually are doing some research in that area. And so from a chemotherapy standpoint, I would say fatigue is probably the number one thing right now. We actually can get around hair loss for the vast majority of patients, but that fatigue and then just the hassle. It's a hassle factor we talk about. You got to come see Dr. Stevenson. He's always late, that kind of thing. It's just coming back and forth, when you're in that really treatment period. So there's that. And then, in terms of like the hormonal therapies, there's a lot that goes into that as well in terms of side effects that can include mood swings and, joint pains and fatigue. Sexual health is a big aspect. Body image is a big aspect. They go through a lot. And so, in terms of, what I would recommend for patients, I mean, I guess, just patience in terms of the family members, patience and try to understand where the patient is coming from. There's moments where you're down and sometimes you don't have to say anything, you just have to be there, be present and listen. Encouragement is huge. Don't fear the unknown. There's a lot of that kind of stuff. So we have some things in place, we try to do it when we see the patients, but we have the Center for Integrative Oncology Services that deal with a lot of these things from a sexual health perspective, from a pain management perspective, from a psychosocial standpoint. Patients come in, they already got whatever baggage they had, and now all of a sudden you're dropping a breast cancer diagnosis on top of that. And the world is a very anxious place right now, and it's a lot that these patients go through. And so we, as providers, need to be just very sensitive to that, and the patient's family and all needs to understand and be sensitive and just be there. I think being present is a number one, and just love them, love them. That's do all that.
I know. Go ahead.
Yeah, I was going to say, do those kind of things, and and then the resources that we have to kind of help augment that. But primarily, it's patience, love, and understanding.
Right. All right. So I think we're at the point where I think Dr. Ane wanted to add something about second opinions, but I think I'm gonna go back to her, and then I'm gonna come back to everybody for final thoughts. If there's anything we missed that you wanted to say. So Dr. Ane, you said you wanted to add something about second opinions.
Sure. Tammy, I think the most important thing is for the patient to be extremely confident and comfortable with the care team that she's with. We always welcome second opinions. I personally welcome second opinions all the time, because at the end of the day, the person who's undergoing cancer care has to be confident that they're having the best care possible. As a team, the most important team member that I said to you is actually the patient and the patient loved ones. Dr. Stevenson had touched upon treatment-related side effects. These are grueling, and they affect the quality of life for not only the person undergoing cancer care, but also their family members. So it's very important for the family to recognize the treatment-related side effects, and also extremely important to seek treatment and or to seek help. The treatment-related side effects could be minimized, mitigated, or treated with integrative oncology approaches like Dr. Stevenson had mentioned. These include things such as prayer, massage, music therapy, acupuncture. These are all alternative forms of stress relaxation and mindfulness. These are all important aspects of cancer care. We have nurse navigators who can assist us in setting our patients up with different aspects of integrative oncology. And there's a lot of science and research that have shown that meditation, prayer, as well as forms of acupuncture have assisted patients through treatment-related side effects. We have to work as a team, and we have to make sure that the patients, when they are undergoing these treatment-related side effects, that they're treated such that quality of life is preserved, because it's equally important as quantity of life.
Right. Dr. Ane, so are those your final thoughts on today's panel?
Yes, ma'am. Final thoughts are, we're here to help our patients, and we want to make sure that our patients are comfortable with their treatment plans, which are going to be individualized based on the patient's medical conditions, in addition to the tumor genomics. And the final thoughts are, quality of life is equally important as quantity of life. Hence, we have lots of integrative oncological services that we would like to have our navigators assist the patients through.
Yeah. All right. Thank you, Dr. Bull.
Yes, final thoughts, get your mammogram. That's the one thing. I've been doing this for over 30 years, and it's really been amazing to me how far we've come with our diagnostic capabilities and what we can do in the mammography suite in the breast imaging centers now. With various, ultrasound has gotten so much better, mammography has gotten better, more accurate. We can see smaller things. We're able to distinguish normal from abnormal better than we were years ago. So it's not a perfect test. We all know that, but it's the best we've got from a screening standpoint for a large population of women. So get your mammogram, please.
All right, Dr. Stevenson.
Yeah, I mean, I think it's just a matter of, it's as we've all alluded to, it's a multidisciplinary approach. It goes well beyond just the medical oncologist, surgeon, and the radiologist, radiation doctor. It is a true village, a true team. And so if you're diagnosed, I mean, that's the kind of setup you want to carry you through. And then I can't, stress enough prevention. We can lean into this, and we can change that 1 in 8 number, and I always it's like this. When I was growing up, I never wore a seatbelt. You didn't have a seatbelt, I don't think, in my first car. Mm-hmm. My kids, seatbelt goes on right away. They don't even think about it. And now, after a long learned behavior, I'm reflexively doing that. The same should be true. Mammography has now been embraced by the vast majority of people across the country. Everyone kind of gets it. Colonoscopy, getting close, but same thing. So this is in that vein. Like, all right, what's your Gale score? You know what your cholesterol score is. You know what your A1C is for diabetes. What's your Gale score? So we're just kind of stressing, normal mammography is not enough. What's your Gale score? Those two together are what I think early detection and what's your Gale score, or how we can move forward in reducing the risk of breast cancer.
Thank you. Thank you. Thank you to our experts here at Prisma Health. It is always our goal to make sure that our community has the information they need to get the care they deserve. Our team, our comprehensive team, is here to help those for things from the screening mammograms through diagnostic and through diagnosis and treatment if that is needed. And so in honor of breast cancer awareness and all of our survivors, we are honored to be here to serve. So with that, we thank our experts. If you have additional questions, you can put them in the chat here on Facebook and we'll try to get you an answer. Also, please visit our prismahealth.org cancer care section that has lots of information, and also prismahealth.org, our Flourish podcast, also both has podcasts and blogs on breast cancer. Thank you for joining us, and we wish that everybody have a great day.
Thank you.
Thank you, Tammy.
Thank you.
Thank you.